evening, everyone. I'm Dr. Ankit Mistry, and behalf of INTAS, it's my pleasure to welcome you all in the 31st Endocrine Talk Show, a testamental to the shared our journey to the learning and the collaboration in the dynamic world of endocrinology. Over the past 30 episode, that this is the platform given to us to brought together and reach discussion and the cutting edge insights and the practice wisdom. Uh, by the all steered by the exceptional guidance of the Dr. Subhankar Chaudhary sir, whose moderation and the clinical acumen as well as his thoughtful provoking perspectives continue to share this or make this series truly impactful. Dr. Chaudhary sir is currently serving as a director of the Department of the Diabetes and Endocrinology Medica Super Speciality Hospital at Kolkata. Today we taken up the topic that often challenge and the puzzles us in the practice. It's a prolactinoma and beyond. In this session we will discuss at the how to correctly the diagnose it and discuss the latest therapeutic approach and understand its effect of not only the pituitary gland as well as the overall health. With these words, I hand over this session to Supankar sir and request him to introduce our eminent panel members. Over to you, sir.
Thank you very much. A very good evening to all of our viewers across the country. And of course, a warm welcome to our panelists. And this evening, as you heard, we shall talk on an area which is not uncommon, hyperprolactinemia, uh, but not that well established, not that well discussed. So can we move on to the next slide? So uh, we are indeed privileged to have an excellent panel of specialists. And first of all, I would like to welcome and introduce Dr. Dibyendu Kumar Ray into our fold, who is a neurosurgeon. He's a consultant neurosurgeon because when we talk of prolactin, hyperprolactinemia, and prolactinoma, possibly there is a role for the neurosurgeon also. So he's a consultant neurosurgeon at AMRI hospitals, which of course is now known as Manipal Hospital. And he has been trained extensively in the US and has also got a diploma from the European Society of Minimally Invasive Neurologic Therapy. We, of course, have our eminent panel of endocrinologists from across the country. We have my very good friend, Dr. Surendra Sharma, who is professor of endocrinology at Mahatma Gandhi Medical College, Jaipur. And he is very well known, doesn't need any other introduction. We'd like to also introduce Dr. Shailesh Lodha, who is again a very senior consultant endocrinologist at Eternal Hospital, again from Jaipur. And he has been very active in improving public education in the field of diabetes and endocrinology, and his efforts have been recognized by the government of Rajasthan. We have in our fold this evening Dr. Shomik Goswami, who is a faculty in the Department of Endocrinology at the NRS Medical College in Kolkata. He's also a visiting consultant at Manipal Hospitals in Saltik and Mukundapur in Kolkata. He's treasurer of the Endocrine Society of Bengal, and he is a very wonderful speaker and a very erudite person. We also have this evening the pleasure of Dr. Priyangvada Tyagi, again, a very promising endocrinologist in our country who is a senior consultant endocrinologist at the Max Hospital at Patparganj, New Delhi. at Hormone India and Shushrut Healthcare in Noida. He was a past associate professor at SGPGI in Lucknow and has been a known face in various national conferences. So, with these, may I get into the job proper? And I would request all of those who are tuned in to try and ask questions, put down your queries, doubts, and those are generally channeled to me in the chat box, and then I can address them to the different speakers. Till such time that we get the questions in the chat box, let's kick off our discussions. Can we have Dr. Somik Goswami telling us briefly about how prolactin secretion is controlled? We do understand uh, uh, different pushes and pulls for various hormone secretions. So, is prolactin similar? Is it different? And that may also help us understand how do we get high prolactin levels.
So prolactin happens to be the odd man out amongst the anterior pituitary hormones. Of course, it's secreted from the lactotropes in the anterior pituitary. But unlike the other anterior pituitary hormones, there's no stimulating factor for releasing prolactin. Rather, it's under the inhibitory control of dopamine, and this dopamine comes from the arcuate nucleus of the hypothalamus along the portal system and acts as a prolactin inhibitory factor to inhibit the release of prolactin. So, are there stimulatory factors? There are no conventional stimulatory factors per se, but thyrotropin releasing hormone, estrogen, have a stimulatory role on prolactin. The other reason why it's the odd man out is because there's no inhibitory feedback of prolactin on its secretion. Unlike the other anterior pituitary hormones, it doesn't have a negative feedback system. So it's predominantly under an inhibitory control, and there's no negative feedback inhibition. And we also need to know that it's released tonically, mainly during sleep, while its levels are somewhat low during the daytime. So this is in brief the physiology of prolactin secretion.
Right. So prolactin is largely under negative control. So if there's for some reason that negative control is lost, then the prolactin level could rise. So now again, before we get into the meat of this evening's topic, can we have Dr. Shailesh Lodha uh, explaining us the functions of prolactin? What does it do normally?
Thank you, sir. The primary role of prolactin is in lactation and reproduction. Whereas in literature, there are over 200 different functions or roles assigned to prolactin. But for clinical purposes, lactation and reproduction are the main functions of prolactin. It stimulates the milk secretion, and during pregnancy, it acts synergistically with estrogen and progesterone, and that is how it helps in development of the breast, the function of which will be available to the neonate after birth. It has some immunomodulatory functions also. One of the important function of prolactin is influence on maternal behavior. The bonding behavior between mother and child is probably because of prolactin. Although there are some interesting facts related to the functions of prolactin in other species, like the nesting behavior seen in birds is because of the prolactin present in those birds. Again, there are several functions, some developmental functions, neuromodulatory functions, immunoregulatory functions, its effects on T and B cells. There are several other functions, but primarily these are the functions which I mentioned.
Right. So as the name suggests, prolactin is related to lactation. We grossly we get it. Uh, can I fall back on the wisdom of Dr. S.K. Sharma? Because
Sure.
now that science is advancing, we now understand that hormones act through receptors, and these receptors are present on target cells. So breast is an important target organ for for prolactin. But now we understand that prolactin is present in so many diverse cells in the body, not just in the breast. So any idea what's prolactin doing in these tissues? of course, Dr. Shailesh did refer to some
Yeah.
immunomodulatory action, for example.
Dr. Salish highlighted all those actions. So in short, I can just say that not only in breast, but it is having multiple, you can say, receptors in many more tissues. And their action is a bit, you can say, very mild to be included into the clinical aspect. But we know that it is a stress hormone. There is a rise in prolactin when there is a stress in our body. Immunomodulatory function is very, very important, that it acts on immune cells. And of course, neurogenesis is also one of the important area. Of course, it involves metabolism, glucose metabolism also. And of course, there are some cases where we know that in this uh, patients who are having prolactin deficiencies, there is body weight changes which are also occurring. So its role on adipose tissue is also to some extent highlighted in our literature. Thank you.
Right. Uh, Something that has intrigued me all along has been that we see prolactin not only in women, but we have a measurable prolactin in men as well. Maybe the levels, the normal levels are slightly lower. So, Shomik, what do you think prolactin is doing in men? They are not preparing the male breast for lactation. Please unmute yourself.
As was being discussed by Dr. Lodha, there are 200 or possibly 300 documented functions of prolactin. So it might have a role in metabolic health because it is known to influence insulin resistance or the adipose tissue function. It has been shown to have an effect on bone health, on hair growth, and so on and so forth. So it has a variety of functions which might be necessary. But we know levels in males are somewhat lower compared to females.
Yes, and I think one of the factors, because I was looking for what could be the possible roles, and I did find at one time that while we talk of and I'm sorry, Dr. Dibendra, if we are just sort of wasting your time, we're talking of various other things, but we'll come back to you.
It's so educative.
Yeah. Yes, Shailesh. Yeah.
Sir, as I said, the nesting behavior in humans also is important. If prolactin is suppose absent in males, then males would not like to live in family. So the
Okay.
family atmosphere is provided by prolactin in both males and females, more so
Okay.
in a lady and her offspring.
Right. So that also gives us some important clues that when we are treating someone with hyperprolactinemia, should we also not try and make sure that the prolactin doesn't go too low? Quite often we get prolactins very low, whether we are harming that lady. Anyway, so what I was saying is I did find out that while hyperprolactinemia is associated with hypogonadism, normal prolactin levels in males are possibly related to a positive effect on the testis. It improves sort of or helps in the normal testosterone secretion. So high levels may be harmful, but normal levels are also important. Right. So can we come to Dr. Priyangvada? So we know the most common effect that we see in women with high levels of prolactin are galactorrhea and amenorrhea and infertility. It will be nice if we did have a hierarchy of level of prolactin related to these various abnormalities. Can we make it that simple? That 50 level prolactin will lead to this symptom, 100 level will cause that symptom, 200 will cause that symptom. Can we say about like that?
So can I just briefly comment on the previous part? So
Yes. Yes.
so parents, fathers who have had newborn babies have shown an increase in prolactin levels. As I was
Acha?
saying, it helps with making them care much for their newborn and also the mother. So
Okay.
that there is a study which I had found which showed that.
So Dr. Sharma and Dr. Shomik, who are now in academic institutes, maybe the next project, DM thesis for one of your students could be related to that. Yes,
So,
So
sir,
what about,
coming to
yeah,
prolactin levels, so as there is no clear cutoff that at this level you're going to have symptom A, at this cutoff you're going to have symptom B. But yes, with a gradually increasing level of prolactin, so somewhere above 50 to say going up to 80, 90, you can have amenorrhea and galactorrhea. Of course, lower levels can also have galactorrhea. Galactorrhea can also be present with normal or just slightly elevated levels. But with increasing levels, there is more likely to be infertility and bone loss. In women, it can lead to disruption of ovulation and so difficulty getting pregnant. In males, it can lead to lower amount of testosterone, leads to impairment in spermatogenesis. So the higher the levels, the more the problems, and problems will start appearing as soon as levels go slightly above 50 to 100 nanograms per ml.
right. So I just wanted to add that again here. I wanted to find out if there's something that we can say more definitively. And what was interesting was that relatively low levels of prolactin, but beyond the upper limit, let's say 35, 40, 50, within 50, they do not usually cause disruption of the menstrual cycle, but they cause luteal phase dysfunction. That's written in textbooks as well.
Yes.
So, and that luteal phase dysfunction can be a cause of infertility as well. So, while we generally are concerned more with very high levels of prolactin, even relatively minor increases may cause problems. So, when we talk of hyperprolactinemia, of course, most physicians would immediately think of tumor secreting prolactin from the pituitary. But as we understand, there could be other causes. So can we have Dr. Somik Goswami tell us about what are the most common causes of hyperprolactinemia?
So by far the commonest causes, at least in a primary care setting, would be drug-induced hyperprolactinemia. And there's a huge list of drugs which can raise the prolactin level. So again, it could be because of the H2 receptor blockers. Even PPIs can raise the level. Both typical and atypical antipsychotics are known to raise the levels. Tricyclic antidepressants, SSRIs are known to raise the level. Estrogen is known to raise the level. Certain anticonvulsants are known to raise the level. Domperidone, metoclopramide. So there's a huge list of drugs which is known to raise the level. There could be physiologic causes as well, like pregnancy can raise the level. Exercise, stress, they are known to raise the level. Chest wall lesions, like you have herpes on your chest wall or a trauma to the chest wall, that can raise the level. And of course, there would be other causes like pituitary stalk section. As we said, it's predominantly under inhibitory control. So any like craniopharyngioma, post-radiation, post-surgery, there's a huge number of reasons why prolactin could be raised beyond the prolactinoma.
Right. So while you are on it, Dr. Aniket Kadre has asked you what could be the approach to differentiate drug-induced hyperprolactinemia versus pathological causes is the exact question that's been framed.
So the
So what do we do?
The easiest way would be to stop the drug. Guidelines indicate stopping it for about 70.
But let's say someone is on antipsychotic drugs. Are you allowed to just stop the antipsychotic like that? Is that fair?
No, that might not be fair. There are two ways out. One would be like if there was a prolactin level available before starting the antipsychotic, that would be of help, which is not often available. The other way out is to look at the level of prolactin. So usually any level of prolactin which is more than 10 times the upper limit of normal is not related to a drug-induced hyperprolactinemia. Although with drugs like risperidone, the levels might be very high, but the usual dictum is anything more than 10 times the upper limit of normal is not usually due to drug-induced hyperprolactinemia. If we could stop the drug, then again, stopping it for 72 hours, but I prefer stopping it for about 5 days and repeating the prolactin to see if it's coming down.
Right. So, Dr. Sharma, can I extend the question? He did mention about 10 times the upper limit of normal.
200 micro.
Yeah. So let's say a lady has a prolactin of 175 nanogram per milliliter. So can it be drug induced, or can we just say it's very unlikely?
So most of the time, drug-induced hyperprolactinemia is in the range of 50 to 100. But sometimes these potent antipsychotic drugs may increase it, as Dr. Goswami highlighted, risperidone, which is very potently increase it even up to 150 or even up to 200 or so. So sometimes we have to differentiate whether it is because of prolactinoma, because of drug induced. So here I want to highlight that whenever we have a raised prolactin, we should first recheck it, because many times if it is mildly elevated, it may be because of other conditions or even stress of venipuncture or breast manipulation, etc. But once we doubly check and it is found to be, let's say, more than 200, 250, most of the time the causes are in the range of, let's say, prolactinoma, microprolactinoma, or macro. In macro, we know that levels may be very, very high. In giant prolactinoma, it will be in thousands, of course, but we have to differentiate drugs. Drugs is very important to rule out a raised prolactin. So as Dr. Goswami highlighted, we have to look into history, look into earlier reports, or if possible, we can change these antipsychotic to drugs like aripiprazole, which is not causing increase in prolactin as to other drugs. And but of course, we have, you can say, consent from our psychiatrist, because if you are reducing or stopping these antipsychotic, patient may deteriorate in the psychosis part. And of course, we have to rule out, so a you can say a MRI of pituitary is very helpful in these type of patients if we are not able to stop in this gray zone of 170 or 200, something like that. Thank you.
Right. Uh, everyone or every other person in our country, or the patient that walks into our clinic, of course, is on pantoprazole and domperidone combination. So what do we do with these people, Dr. Priyangbada?
So stopping the medication for 72 hours, and so, as sir rightly said, preferably for up to 5 days, will lead to rapid normalization of prolactin levels. And so after that, patient should be counseled to avoid these particular drugs in future and could be switched to an alternative drug therapy. If
But what alternative? So would
H2
vonoprazan
blockers like
be good?
ranitidine could be safely used in these patients.
Is that okay? I mean, ranitidine, or is that better alternative? No, first of all, do proton pump inhibitors, do they cause the problem, or is the domperidone
It's
or
the
the
domperidone.
levosulpiride or etopride that goes with it that causes the problem? I mean, the major problem I feel is related to the other part,
Yes.
less to these two or the proton pump blocker, right? So, Priyank, staying with you. So, Shobik did say that prolactin levels can be raised in pregnancy as well. So, how high can they be? Can
So,
it be just 30,
sir,
40?
levels,
Or,
so
yeah.
prolactin levels will start to rise as early as immediately after the conception, and they will gradually increase up to third trimester and can increase up to 300 to 400 nanograms per ml. This is predominantly due to estrogen stimulated increase in both the number and the size of the lactotrophs in the pituitary, and help prepare the breast for the breastfeeding of the neonate.
Okay, right. So now we come to Dr. Shailesh Lodha. So we have a 30-year-old lady with galacturia, amenorrhea, infertility. She has got very high prolactin, let's say above 200. She's got a microadenoma on MRI scan of the pituitary. And now how do you treat? You have to unmute yourself.
Shailesh, unmute yourself. Yeah. Unmute.
Oh, sorry. So, as we know, demonstration of microadenoma on MRI may not necessarily be microprolactinoma. It could be just an incidentaloma. So first, we have to check the levels. As you said, it is 200. So unlikely to be an incidentaloma. and probably we are dealing with pituitary microadenoma. So the first aim is to bring down the serum prolactin levels, normalization of prolactin levels, and then restoration of menses. And if it is chronically elevated prolactin, then we have to take care of the chronic disorders due to hyperprolactinemia like osteoporosis. And of course, to give symptomatic relief like galactoria to the patient. If headache is there, then again we have to give symptomatic relief. So the first and foremost choice in this situation is the DOPA agonist in the form of cabergoline. We are now these days not using bromocriptine, which we have all have used 1 or 2 decades ago. And as we know, microprolactinoma is generally less than 10 mm. So it is generally asymptomatic, except galactoria, amenorrhea, or symptoms related to these reproductive part of the lady. And bromocriptine, we have to start with a low dose and go slow, 0.25 milligram twice a day can be started if somebody is able to
We're
tolerate.
talking of cabergoline. We are talking of cabergoline now.
Cabergoline, sir.
Or,
Yeah.
So
cabergoline, we have to start considering the level of 200. I think even if we start at 0.5, it's fine. 0.5 milligram twice a week. And then after 4 to 6 weeks, we can repeat serum prolactin. If there is a significant drop, we can continue with the same dose. Or if there is no significant change, we can again increase the dose. Likewise, every 4 to 6 weeks, we can reassess the situation. And the first relief the patient will get is relief in galactoria. And after a couple of months, there may be restoration of menses. And at the end of 6 months, we may get an repeat MRI to see change. Between 6 months to 1 year, this is the good time to get a repeat MRI. However, if the patient is symptomatically better, everything is going on nicely, we can go on for 1 year. And then we can taper off the dose of cabergoline.
Those are very important issues as well. And so first of all, Dr. Rahul Joshi had asked already. One is how often to repeat MRI or prolactin. So I think you have given some guidance, maybe the first time, maybe after 6 weeks or whatever, the prolactin level. And the MRI is not too soon, probably not before 6 months. Of course, if you have a big tumor, then maybe, again, I think at least 6 months before that, possibly we don't need to do another MRI. So, but this lady had infertility as a complaint. So at 6 months, maybe she's having regular periods, no more galacturia, the prolactin level has dropped to, let's say, 20 or thereabouts. So what do we advise regarding pregnancy? And she's on cabergoline.
Yeah, cabergoline is quite safe during pregnancy. She can go ahead because there are high chances that if we stop cabergoline abruptly, there might be again a rise in serum prolactin. So we have to treat these microadenomas for a little longer time. So we can very well ask the lady to go ahead with pregnancy. She can continue with cabergoline, and as soon as the pregnancy is confirmed, cabergoline can be withdrawn. But there are some different thoughts here. Few people would like to continue cabergoline during pregnancy also for at least for 3 months. And since it's an microadenoma, we can very well stop during pregnancy. If had it been a macroadenoma, then maybe cabergoline would have been continued even during pregnancy.
Right. So I mean, the dopamine agonist, at least cabergoline, also initially bromocriptine had been shown to be fairly safe in pregnancy. Even cabergoline, at least, has been shown to be reasonably safe. So now we switch gears. Maybe now we have a gentleman. So it's not just women only who have hyperprolactinemia. Men also have hyperprolactinemia, and sometimes at least the levels that we see possibly are much higher in men than in women. So we have a 35-year-old gentleman who has loss of libido, has low testosterone. He has very high prolactin, 500, more than 500, and he has got a very big macroadenoma on the MRI scan, which is impinging on the optic chiasma. Maybe there is mild or no visual field defect, or maybe just mild superior quadrantic field defect. So now this patient comes to you. So do you take on the responsibility, or do you ask Dr. Dibendu Roy, who is with us, and take his opinion what to do?
Still, I will like to treat the.
No. So this is sorry. This is for Dr. Priyank.
Okay, yeah.
So, okay, sir. Sir, so first of all, I would like a formal evaluation of the visual fields. So if it is just mild, I would like to initiate cabergoline, because even though it's a macroprolactinoma, but if it is confined to the, if it is not too extensive, not invading into the cavernous sinuses, it will respond very well to medical management. But yes, if but resume normalization of prolactin levels will take about a few weeks, and reduction in tumor size will take up to 3 months in such a patient. I would like to get a perimetry get done again at maybe about 4 to 6 weeks. If it worsens, then it is time for the neurosurgeon to step in. Of course, in the current scenario, I would always like to involve a neurosurgeon and give the option to the patient that a surgical debulking initially in a macroprolactinoma could be considered.
So can we now invite Dr. Dibendu? So if, let's say, two scenarios, the patient decides that he wants to go to you, that's one. Maybe the commonest scenario would be Dr. Priyank would already have started him on cabergoline and then lands with you. So if he comes to you after being put on cabergoline, are you unhappy that your surgery is made more difficult? Because that's what we physicians quite often hear from neurosurgeons, that exposure to cabergoline makes the surgery more difficult. Is that correct?
Yes, sir. It is well known that the tumor becomes fibrous. Normally, pituitary tumors, when we access through the small, the endoscopic approach that we do nowadays, we would prefer the tumor to be soft and come out as easily when we do the curative. But when the tumor becomes fibrous, there's a risk of injuring the hypothalamic pituitary axis and going into or resulting in pituitary insufficiency. That is something that we would not want. If the tumor is near the optic chiasma or impinging on the optic chiasma, has already started causing some visual deficits, we would prefer to do a surgical debulking and hand the patient back over to you all so that you can continue with the medical management of the patient.
So if the patient, let's say, came first to you because you also had headaches, and would you give him a hope that you will be curing him of his tumor?
Sir, it depends on the NOFS reading that we can do, whether if it is
right. Okay, so yeah, please go ahead.
So if we think that it is definitely invasive or it is moderately invasive, we would tell that he and the patient already has developed some visual deficit. We would prefer to debulk the tumor and say that he will require follow-up. He or she will require follow-up with medical management with his treating endocrinologist. If the tumor is non-invasive and has only some optic, involvement, or has come to us with an apoplexy, we would prefer that we debulk the tumor and then follow up with serial prolactin levels and see whether the prolactin levels are going down. Because often, if there is an apoplexy, the tumor doesn't grow back in the case of a macroprolactinoma.
Right. So that brings to another issue, apoplexy in a pituitary tumor. Is that always a surgical management, or is there conservative management or as well? Show me.
Yes, there could be conservative
Yes,
management, especially
yeah, doctor.
if the patient has not developed a visual deficit or is not having any intractable headache, if it's mild headache and the visual fields are still intact, I would prefer that the endocrinologist manage the tumor, and it's fine with us.
Right. So when we send to the neurosurgeon, maybe ultimately they need to learn from you exactly what you're going to do, but still patients do want to have an idea of what is the operation, how it's being done. So what are the ways that you would manage a pituitary tumor surgically?
So initially, when we were residents, we learned to do with the transnasal, transsphenoidal approach. But as things have progressed and we have had more access to endoscopic techniques, we now normally do the transnasal, transsphenoidal endoscopic route. We go straight up to the sphenoids ostium.
So what's the difference from the past? It was transnasal, transphenoidal in the past. Now what does it become?
It's still transnasal, transsphenoidal, but we do not do the submucosal dissection right from the nasal ala. We go right down to the sphenoid ostium, enlarge the sphenoid ostium, push over the heel of the vomer, and enlarge the sphenoid ostium on both sides and get access to the sphenoid.
Okay. Right.
So crusting and all are lesser.
Okay. And is there some difference between standard endoscopy versus microscopy?
There, obviously, endoscopy gives us a much better close-up view of the tumor cavity. We can take the endoscope either with the 0 degree or the 30 degree right up to the cellar, inside the cellar, and look at the tumor and see whether there is any remnant on the walls of the tumor capsule. And normally we do not do any cautery out there because of the risk of injury to the carotid, but we can do a direct pressure, and if there is some venous oozing, the oozing stops much better. Earlier used to have some bleeding inside the cella after a microscopic approach, but now those are well taken care of.
Right. And we have heard of something called neuronavigation. So is this a great advance? Is that what neurosurgeons nowadays use at advanced centers?
The neuronavigation is definitely helpful, especially it helps us know the exact position of the carotid arteries, where to incise the dura so as to avoid injury to the carotids and the inferior cavernous sinus. So chances of vascular injuries are much less.
Right. So excellent. So we have got a fair bit of idea about what the how the neurosurgeon can help us. Now, there are instances. So we have got a question here, Dr. Satyajit. Maybe Dr. Sharma, for you. At what point should the consultant consider bone mineral density testing in patients with prolactinomas?
So we all know that if a patient is having long duration of hyperprolactinemia because of prolactinoma, and hypogonadism, as we all know, lead to bone loss. So we should go for bone mineral density in these type of patients, particularly if the patients are elderly or post-menopausal ladies. Then it will be very, very useful, because long-standing hyperprolactinemia is also linked to osteoporosis. So whenever we get these type of patients of prolactinoma, we look into what is the age of the patient, very young or middle age or elderly. what is the level of prolactin at the baseline, and of course the size of the tumor. And then accordingly we decide whether we are dealing with a microprolactinoma or macroprolactinoma, or sometime, rarely, not common, giant prolactinoma. And in this long-standing diseases, of course, we get this bone mineral density also.
Right. So if it's been long standing, then we should be looking at bone density. Right. Now, it has been an experience with all of us, I'm sure, that sometimes the prolactin level does go down, but the tumor doesn't shrink that much on medical treatment. On the other hand, there have been instances where the tumor has shrunk, but the prolactin has not decreased so much. So, is there an explanation, or do you see that? What do you do there?
Most of the time, these two things are going parallel. So there is hardly any discrepancy in most of our patients. So when we start treating these patients and we gradually increase the doses of cabergoline, we found that within a period of 3 months or so, there is a very good decrease in prolactin. And of course, size of the tumor is also decreasing. Most of the time, we say 30 to 50% reduction in the tumor size is there. And we are happy and we continue with therapy. But sometimes these discrepancies are there, that prolactin levels are going down, but still tumor is not shrinking as we are expecting. So in that scenario, probably because prolactin is decreasing, so we will be happy to continue with this treatment. Let's say for microprolactinoma, we say that we can go for a duration of 2 years or so. But when the prolactin is not decreasing and tumor size is decreasing, then of course we have to look into other causes of, you can say, hyperprolactinemia, whether the patient is having hypothyroidism or renal insufficiency, hepatic insufficiency, etc., or the patient has started taking again domperidone type drugs. So history is to be looked into, because the level of prolactin is not going down, or the patient was put on some estrogen therapy, etc. So these are some of the things. But continuing with bromocriptine for a more time will tell us whether we involve a surgeon there or not, if tumor size is not shrinking. Thank you.
Right. So, Shomik, so we heard about continuing dopamine agonists, and we have a question in the chat box. Dr. Rahul Joshi wanted also to know when to stop dopamine agonist therapy. So, how long can we continue this treatment? And the million-dollar question, can you cure a prolactinoma with your medical treatment?
There are two parts to the question. How long do we continue therapy and can we cure? And these actually have different answers, because as per the standard guidelines, you need to treat for at least 2 years, after which preferably there shouldn't be any residual tumor, or there should be substantial reduction in the residual tumor to the tune of, say, less than 5 millimeter at least. And your prolactin level should be normal, when you can think of tapering the dose, and after 6 months, that is after 2.5 years, you can stop therapy. So after you stop therapy, you need to monitor the prolactin every 3 months for 1 year, and then yearly, annually for the rest of his or her life. It's a lifelong monitoring. The reason being that although remission is reported in, say, around 70% of microadenomas and in around 60% of macroadenomas, cure, in the sense that lifelong cure, happens in only about 30% of individuals. So remission is known. So after 2 years of therapy with tumor shrinkage or absence, normal prolactin, we can stop and then monitor. But only around 30% there will be permanent cure. In the rest, there might be a recurrence, so lifelong monitoring is necessary. There's an interesting thing here, which is that there are two situations where cure might be more common. One is pregnancy. So following a pregnancy, about 2/3 of both micro and macroadenoma might go into long-term remission or even cure. And the same applies for menopause. So following menopause, a good number, again about 60 to 70% of these prolactinomas are known to go into long-term remission. So this is how things stand.
So, but how do you stop? How to decide to stop?
So after at least again 2 years of therapy, not before that, if you have no
Yes.
tumor on MRI, well and good, or certain studies have shown that when the tumor size, maximum size is at least less than 5 millimeter, and you have a normal prolactin, preferably a suppressed prolactin, I would say. Studies have shown less than 3 is good. You can down titrate the dose, follow up the patient for the next 6 months. If things still look good, then you can stop. Again, monitor year for the first year every 3 months and then annually for the rest of life. That is how we can do
Right.
it.
Right. So when we have a good response, then we can gradually think of withdrawing also, but with the full knowledge that there can be recurrence of the prolactin levels going up. So when we talk of long-term treatment especially, but even in a short term, uh, what are the adverse effects of these class of drugs, Dr. Priyangvada? And do we need to do any special monitoring?
So the most common side effects that the patients experience are GI side effects, which would include nausea, vomiting, stomach upset. A certain proportion of patients will have dizziness. Uh, Rare side effects would be neuropsychiatric complications, which would include uh, impulse control disorders, which happen in a select group of patients. It also can lead to higher incidences of hypersexuality in males, especially when testosterone replacement is being given, along with the continuation of dopamine agonist therapy. If
So can I quickly ask our endocrinologist colleagues, how often do you see these in the patients of, let's say, prolactinoma that we treat? Dr. Sharma, quickly.
This impulse control disorder, sir, or
Yeah, I mean,
overall side
all of
effects. Overall
overall
side
side
effects
effects.
like GI side effects are not uncommon to start with. So nausea, vomiting, dizziness, nasal stuffiness, these are seen. But as we continue to give these drugs, there is a gradual decrease in these side effects. And then,
Okay.
of course, we can up titrate the doses and patient can tolerate those higher doses also now. So to start with, these patients are usually complaining of, but most of the time these drugs are not having that scenario that you have to withdraw the drug. Rarely we have these type of patients. And then of course, recommendations are that you can change the drug. Like if you are giving bromocriptine, then you can go to the cabergoline, or if you are giving cabergoline, you can shift to bromocriptine, etc.
Yeah.
So these are some of the things. But these impulse control disorders are not very common, but sometimes people say these are seen not only in hyperprolactinemia, but also in other pituitary tumor surgeries and other tumor treatment. But it is rare. And as Dr. Premda highlighted, that hypersexuality is usually because on one hand you are cutting down on the hypogonadism and you are substituting testosterone in male, and then they develop. Or sometimes they have, you can say, gambling, etc., or they go for
Impulse. Yeah.
impulses of buying things
Yeah.
every day, something like that.
Yeah. And many of the GI side effects, at least for you and me, and maybe Shailesh also, from the bromocriptine era, from the whatever
Yeah, old age.
old age. So maybe the GI side effects are definitely much less with cabergoline, but they can still happen. Yes, Shailesh, a quick word on this.
Yes, sir. I totally agree with the discussion which was going on. I think there is hardly anything which I can add. Only one thing I
Right.
remember: if these drugs are used chronically, then there might be some changes in cardiac valves.
Okay.
So
Yeah,
if you
maybe.
are
Yeah,
if you are,
Prangmada, maybe. Yeah,
if you are
she'll.
using it beyond 2 years, then annual echo is mandatory.
Okay. Yeah, Prangmada, please continue.
So, sir, at doses less than 2 milligrams per week, it can be prudent to do it every 5 years. But more than 2 milligrams per week, yes, of course, you need to do it every year. Or earlier, if patient complains or there is a heart murmur.
So that's the only thing that you need to monitor
So
in
we don't
relation
need,
to
so
adverse
there are
effects?
incidences of heart failure also associated with the long-term use of dopamine agonist. So symptomatically, patient needs to be carefully asked about all these complications. And if the patient complains of any such events, you should get an echocardiography done.
Yes, Dr. Sharma, you
Yeah,
wanted to,
sometimes when
yeah.
we start treating our macroprolactinoma, then sometimes there is a rapid decrease in size, and these patients may have CSF rhinorrhea. So that is also to be looked at. That is not the side effect of the drug, but the excess effect of the drug. So shrinkage, and then there is a leakage of CSF. But we have to reduce the doses and then follow these patients.
Right. So maybe we will try and gradually wind up, but uh, when we talk of duration, we talked about how long we can continue. So what is the maximum dose that you can go to, Dr. Shomik?
So the usual dose that is approved is up to 2 milligrams per week. And just to add in, one of the ways of reducing these adverse effects is to dose it at bedtime so that the peak effect goes when the patient is asleep or supine. Uh, if patients do not respond to 2 milligrams, there are some recommendations of going up to 3.5 milligram. There are rare reports of going up to 12 milligram per week, but that's an exception and should be done only under expert supervision. So the usual dose is up to 2 milligram per week, in rare instances up to 3.5 milligram per week.
And then if the patient has not responded to 3.5 milligram, do we say that this is a resistant prolactinoma?
Yes, so from the threshold of 2 milligram itself, we can define that it's a resistant prolactinoma. And of course, 3.5 milligram would be a resistant prolactinoma as well.
Right. So, Dr. Dibyendu, so these patients should be sent to you, those who have not responded adequately to medical
Yes,
treatment.
yes. One of the indications for surgery in prolactinomas is that if patients are unresponsive to medical management, or they come back from remission after you stop medical therapy, then we have to give it a try. If we can take out most of the tumor and it is not fibrosed.
Right. So just one more point about you were mentioning about the NOSP grading. So if the tumor has indeed extended laterally into the cavernous sinus, and if we have a transsphenoidal route, is there no way with the modern whatever the endoscope, can we not take out some of the laterally located tumors?
There we can of course try, but with the loop of the carotid artery there, neurosurgeons are very apprehensive. But we have other modalities, like we can use the gamma knife to burn off whatever is left out there if it is not treatable by medical therapy, or the patient's prolactin levels have again gone off after you have stopped your optimum medical management. And if it is extends beyond the carotid artery, beyond the sella, then of course we have to, if it is not responsive to medical management, we have to take help of other modalities like radiosurgery to give relief to the patient.
Okay, right. So I'll ask Dr. Shailesh Lodha with a specific example. So we have a 38-year-old lady who has got a microprolactinoma, who has completed her family. Her prolactin level is now 80 nanogram, let's say 100 nanogram per milliliter. She has mild expressive galacturia with which she is not so much bothered, but she is amenorrheic. How should we treat?
So at this stage, sir, the age is in the gray zone. Had it been 3 or 4 years more, with very minimal symptoms, I think a watchful waiting is one of the way to go ahead, because fertility is not in concern and periods are also not a concern. But if period is menstruation is a concern, then of course we have to treat. this lady, because if this hyperprolactinemia goes on for a long time, this lady will develop premature osteoporosis. So a lower dose of maybe 0.25 milligram of cabergoline once a week would be enough. And of course, I presume that all those drugs which we have discussed have been taken care of, that she is not on any of such drug.
Right. Yeah. Yes. And let's say we have a similar situation where the person has not responded to whatever Shomik has defined 3.5 milligram per week of cabergoline. She's still amenorrheic. Prolactin is still high. Can we use estrogen here?
Yes, sir. Estrogen therapy, it can be used to normalize the menses.
But Shobik told us very early on that estrogen causes stimulation of prolactin. So we will be further adding fuel to fire?
No, I don't think so. And in resistant cases, of course, there are other options also. Surgery is one of them. Otherwise, temozolomide is one such option available today to us that can also be utilized.
Right.
So the estrogen increased prolactin,
yes.
and the size of the prolactinoma is very mild. So estrogen therapy can be given to make sure that the menstrual function is okay and the bone density is not worsened even further.
And the doses which we are giving, sir, in these patients are very low. The estrogen which is given in high doses are causing increase in prolactin. So in our usual practice, we are not using that high estrogen. So we can continue with estrogen in that lady if she is not bothered about amenorrhea and mild galactorrhea.
Right. And we have a question from Dr. Ritesh. How do you treat hyperprolactinemia induced by SSRI in patients in whom stopping the drug is not an option? Dr. Shailesh?
Yes, sir. I think we have discussed this question earlier also. So it is better to shift to some other safer.
So which for antidepressant, which one would you suggest?
Bupropion.
Of course, we can say it's the psychiatrist domain, but many a time maybe we can sort of guide them, suggest that whether such medication could be used.
I think bupropion is one such option.
Yes.
Or
aripiprazole. I think bupropion and mirtazapine are two agents which cause least prolactin problems. So maybe we could suggest to our psychiatrist colleague.
And sir, if the levels are not very high, they are mildly elevated, we can continue with this drug because patient is not having galactorrhea or amenorrhea. But if the symptoms are there, then of course.
Yes. Yeah. But that is a real tough situation, because in most instances, psychiatrists would say, no, this is the best drug for my patient. I cannot change it. And then can we add a dopamine agonist? Shomik?
So the conventional thought was that if you add a dopamine agonist, that can lead to worsening of psychosis or depression. But again, if we look at recent literature, it says that there has been a publication bias, because the cases where worsening has occurred has actually been reported. So we can start low doses of cabergoline and look at the response. If there's no worsening of depression or psychosis, we can continue with the cabergoline.
Right. My bias is for SSRIs, possibly. I mean, they would not be worsening, but for psychosis, because dopamine is the agent that causes the psychosis. If you're increasing that, maybe we could. But I do understand.
We could consider quetiapine or aripiprazole because they are safer agents. If possible.
Yes. Right. So can we now ask Dr. S.K. Sharma to comment on the latest Pituitary Society International guidelines on microprolactinoma? And I'm sure Dr. Dibendu is also there, which suggests that you should offer surgical treatment to microprolactinoma. We thought that we as physicians, as endocrinologists, this is one area where we offer so much of value to our patients. But at least the guidelines would suggest that even for microprolactinoma, uh, medical treatment is bettered by surgical treatment because you offer a chance of cure. So, what are your views?
Sir, it all depends upon the level of prolactin, size of the tumor, and then age of the patient. So if the patient is menopausal, then we can just follow the patient, observe the patient. If the patient is premenopausal, then even if the patient is not bothered about galactoria, amenorrhea, even we can follow, or we can give hormone replacement therapy. Then if very young patients who are male and then have more of these chances of macroprolactinoma or giant prolactinoma, of course, surgery will be a definitive treatment in those patients. Sometime debulking with surgery and then followed by, you can say, even cabergoline is also there. So most of the time,
No,
these new
yes, Dr. Sharma, but the sort of the emphasis is on microprolactinoma, where there is a chance for cure. For you, with medicines, you cannot say yes with hand on your heart that yes, I'll be able to cure the tumor. But the surgeon, the
absolutely.
possibilities are more. If you have a bigger tumor, yes, debulking you can do, but chances of cure even for a big tumor are much less with surgery. So the surgery should come in for microprolactinoma, which is sort of opposite to what we have generally thought about or
Yes, you are
dealt with.
absolutely right, sir. Most of the time, surgeons are not required, but there are instances where patients who are having very young age, and then you give options of continuing that therapy for a very long time to these patients, vis-a-vis surgery, where in microprolactinoma, surgery is having better results as compared to macro. So patient's choice is also to be looked into.
But sir, like
Yes,
it
friend brother.
often is said that for a young woman who's planning pregnancy, you could offer them the option of surgery. But then there is also an option of inadvertently damaging the rest of the profile, which could lead to problems in conceiving naturally. So then they would have to be on assisted technologies and give others. So this is something we have to balance.
Right. Is Dr. Dibbendu still around? Right.
Sir, yeah.
Yeah. So do neurosurgeons operate on a lot of microprolactinomas?
In fact, we don't. We only operate on microprolactinomas when we are referred for usually two instances. One, if the patient is intolerant to medical therapy. Two, if the patient refuses medical therapy and wants some options regarding surgical management and cure. Because frankly, finding out microprolactinoma, if we are not using uh, image guidance, sometimes it's difficult, and we may cause more damage to the gland, and the patient may end up requiring hormone replacement for life.
Right. So despite the international guidelines, possibly on the ground in our country, possibly still it's more a medical management. But of course, we will need our neurosurgical colleagues in specific instances. So I think, friends, we had a good discussion, and there was constant questions being put in by our audience, and we did cover about prolactin, what it does, how it's secreted, and what are the causes for high prolactin, especially stressing that drugs could be an important cause for high prolactin, so we should always try and exclude that. And then, of course, you can have a prolactinoma, you can have a small tumor, you can have a big tumor. And sometimes, which we did not cover, is that you can have a big tumor in the pituitary region, which is not producing prolactinoma by its own, but by causing something like stalk effect or whatever, by affecting the pituitary stalk it can lead to high prolactin levels, where the prolactin levels are usually not that high. So, and we have good medical treatment, and of course, there will be instances where surgery would be indicated. So, can I have one final look at if there is any question in the chat box? No, right. So I would like to thank once again our panelists this evening, our guest panelist, Dr. Dibendu, the neurosurgeon. Thank you very much for your insightful comments. And of course, our endocrine colleagues, Dr. Surendra Sharma, Dr. Sailesh Lodha, Dr. Sobhik Goswami, and Dr. Priyanvada Tyagi. And of course, thanks to INTA's team for taking the interest over the months, over the years actually, to perpetuate this sort of program, which brings common important endocrine topics to the, let's say, in the grasp of the physicians across the country. So thank you very much, all of you, and over to the organizers.
Thank you, sir. Thank you, Shubhankar, sir. Thank you so much for once again anchoring this program. And we had an audience of more than 2,100 doctors live, sir. So I think this testifies the kind of interest this program is generated. This is the 31st episode, and I would really thank you for taking this forward. I would also take this opportunity to thank Dr. S.K. Sharma, sir, Dr. Soumik Goswami, sir, Dr. Shailesh Rao, sir, and Dr. Priyamvada Tyagi, ma'am, for taking time out, sparing their valuable time, and being a part of this program. Thank you so much, and thanks a lot, sir.
Good night.
Thank you.
Good night.
Thank you very much.
Good night, sir.
Thank you, sir. Good night.
Thank you, sir. Good night.